off, I just want to thank everybody for having me here and everybody who already spoke. It makes my job a lot easier, I think, to try to talk about management after such wonderful presentations about pathology and radiology. So, I was asked to talk a little bit about the management of ILD, and he mentioned that maybe we have less challenges, but I'm not so sure. It's a really challenging field. So I'll try to make sense of it a little bit as we go. I'm a pretty informal person, I'm not even wearing a tie, so please ask questions. You can raise your hand at any time. Okay, so we've covered some of this, but just to give us an idea of what we're talking about. So the interstitium is the space between the capillaries and the air that enters into your lung. And that's the space where gas transfer occurs, okay? And they already brought up a very important point, which is this is a misnomer. Interstitial lung disease, one of the things that makes it so confusing is that people have put in any rare disease that happens in the lung and called it interstitial. There are ones that happen in the alveoli, there are eosinophilic lung diseases, and they call all these interstitial. And they're really not. But us interstitial lung diseases, because we like odd and rare things, us who specialize in it, we end up taking care of all these people. So you can see in the far right picture, as macrophages come in and you have more fibroblast activation and you thicken the space between the air and the blood, gas transfer suffers. So patients become short of breath. That inflammation also causes irritation, which leads to cough. And these are usually the symptoms that patients present with. I thought I would try to keep this as basic as possible, and I'll get into the details a little bit later. But first off, these diseases are complicated and they're rare. And so management really should be with somebody who specializes in the field. And it's multidisciplinary. So I tried to make some things simple. So these are my rules for all ILDs, okay? All ILD requires a CT scan. Preferably high resolution. I would say always high resolution if you have it, but I understand that there are limitations, right? All ILD requires monitoring. These are heterogeneous disorders. So some will progress and some will not. Some people will get worse quickly, some will not. And monitoring these patients is how you decide when to treat and when to change treatment. All ILD requires a diligent and exhaustive history and exam to reveal etiology. We'll talk a little bit about this as we go forward, but ILDs can all look alike. The pathologists brought this up, our radiologists brought this up, and without clinical history, you won't know why your patient has the sickness that they are presenting with. All ILD requires multidisciplinary care. I think you saw that already. I need my pathologists, I need my radiologists, I need my internal medicine doctors to send me these patients. All ILD requires supportive care. So there are some simple things you can do. Patients that need oxygen should try to get it if it's available. I understand there are limitations. Patients can get pulmonary rehab, and there's evidence that supports that that's helpful. And patients should be referred to palliative care. Finally, approach a biopsy with caution, but not with fear. So it is risky to put people forward for a biopsy. The quotations are that the mortality for a biopsy in somebody with IPF is 2 to 3%, which may not seem so high, but this is something that is not treating the patient at all. It is just answering a question. For some context, to do a bypass surgery, like an arterial bypass surgery in the United States, the mortality is about 4.5 to 5%. So that's a pretty high risk when you're just trying to get a diagnosis. However, what the diagnosis is can change your management. So approach it with caution, but not with fear. Here's some for specific ILDs. You can tell that we like a lot of stuff. ILD people like a lot of words and a lot of letters, so I can't just have a short list, so I have to keep going. So ILD associated with an exposure requires removing the exposure. Okay, pretty basic. ILD associated with an underlying disease requires treatment of that disease. IPF has treatments that differ from other treatments in ILD. And IPF worsens with immunosuppression. So these are things to kind of remember. And I'll talk about idiopathic pulmonary fibrosis more. So we've already had a really good overview of the diagnosis and how to kind of work this up. And I'll talk a little bit about this, but really what I'm focusing on here is treatment and monitoring, okay? And I tried to highlight diseases that I think are common enough to make it worth our time. Everybody's shown a slide like this. It's just to show that there are a lot of these. There's 200 different types of ILD. So to be tasked with telling you about the management of 200 different diseases in 15 minutes is quite a challenge. But I think you can get the idea that there are a lot. And if you look at this afterwards, I'll distribute my slides if people want. One of the things you find is that figuring out what differentiates each one of these, a lot of it is about history. It's about what the exposure is. It's about what the underlying disease is. So how about we simplify this a little bit? So there are interstitial lung diseases that are related to exposures, okay? Mold, feathers, inorganic dusts like silica, asbestos, or the pneumoconioses, and then drugs that you take for medication or for recreation, and tobacco. And these can have patterns that look like different things on a CT scan. So because you're exposed to this, you might have an NSIP pattern, or you might have diffuse interstitial pneumonia or respiratory bronchiolitis with interstitial lung disease or these other kind of patterns. And the treatment for most of this is sort of similar. It's remove the exposure and then you consider immunomodulatory therapy, generally prednisone, okay? Then there are the ILDs that are due to an underlying disease. Connective tissue diseases, maybe HIV. The diseases that commonly cause this: rheumatoid arthritis, lupus, Sjogren's syndrome, scleroderma, myositis, EGPA and GPA. And these can cause patterns, again, that you'll see there's overlap. You can have NSIP with exposure or NSIP with an underlying disease, again highlighting history. You don't know why that pattern is there. You need to figure it out. Finally, there are the idiopathic or genetic causes. And these are idiopathic pulmonary fibrosis, sarcoidosis, cryptogenic organizing pneumonia, idiopathic nonspecific interstitial pneumonia. And then there's some really rare ones: eosinophilic pneumonia, pulmonary alveolar proteinosis, and LAM. And you know, one thing I don't have listed here, but I wanted to mention as I was thinking about it, look at the Langerhans cell histiocytosis X-rays and CTs and think about that for your patient, okay? And we can talk about it afterwards. So going again, try and keep it simple. So what you should do for all ILD, check NO2 sat at every visit. If the patient can get oxygen and they drop below 88%, give them oxygen. If they can't get oxygen and they're dropping below 88%, have a talk with them about it being a poor prognosis. Enroll patients in pulmonary rehab. Anybody who feels like they're short of breath with any sort of exercise can be enrolled in pulmonary rehab and have benefit. And there's studies that have been done that show this is true. And we have pulmonary rehab at MLI. So it's certainly something that we can do. Treat their symptoms. Patients that cough, give them cough syrup. There was even a trial where they looked at thalidomide, you know, the drug that we don't use in pregnant women, for IPF cough, and it had a benefit over placebo. Most people that have idiopathic pulmonary fibrosis are over 60 years old, so you don't have to worry about pregnancy. So it is something you can do. Treat their pain if they have chest pain. And if patients are at end stage, consider opiates for air hunger to decrease symptoms. If patients have acid reflux, treat it. There's been studies that show that untreated acid reflux can lead to rapid progression of interstitial lung disease. Some proton pump inhibitors can't interfere with medications. I just wanted to put that up, so keep that in mind. Avoid smoke. Avoid things that make interstitial lung disease or any lung disease Vaccinations. If there's vaccinations available locally, give them to your patients. A pneumonia would be devastating in somebody who has interstitial lung disease. And palliative care. We talked about it. In general, these diseases do have a poor prognosis. They're getting better, and I'm going to give you guys some hope in a second. But you should discuss it early, and if it's available, refer. I know there is palliative care available in Kampala. So let's talk about autoimmune ILD. So high-quality trials are usually lacking. And a lot of the reason for that is that these are really rare, and it's hard to get a lot of numbers of patients. Really, serology, like ANA that we had in the first patient, is kind of necessary to rule out connective tissue disease or autoimmune disease, because lung disease can be the first manifestation of a connective tissue disease. So in the ATS guidelines, for example, it says that all patients who present with ILD should have this panel of autoimmune tests. I know that's not necessarily realistic, but I'm just giving perspective. So if you find an underlying disease, treat it. Treat it with the evidence-based guidelines for that disease. And think of the lung as just another organ that's getting affected. So if somebody came in with rheumatoid arthritis and their hands were hurting more and they were on a low dose of prednisone, you'd go up on their prednisone. If somebody with rheumatoid arthritis has lung disease and they feel more short of breath, go up on their prednisone. That's a manifestation of their rheumatoid arthritis. Monitoring PFTs is important if you can, because often this will give you a clue that there's progression in their lungs, and that'll help you to change therapy or step up therapy. If you're using prednisone, it's likely that it's going to be long-term. You want to use the least prednisone possible to stabilize their lung function. And if they're going to be on high doses of prednisone for a while, consider Bactrim for pneumocystis prophylaxis. Okay. That's gotten forgotten in the US often. And ensure monitoring for side effects, decreased bone density, weight gain, things like that. So I thought I'd talk a little bit about some trials to show that there is progress. So there have been 2 trials with scleroderma, which is kind of the most common disease that has interstitial lung disease. SCL1 and SCL2 were the names of the trials. Scleroderma lung 1 and scleroderma lung 2. And the one that's on the left there, first they did cyclophosphamide versus prednisone, and they showed that cyclophosphamide, when given as opposed to low-dose prednisone, stabilized lung function better. Okay, so people had less decline in lung function if they got cyclophosphamide. A subsequent trial looked at mycophenolate, or CellCept, versus cyclophosphamide, and found that mycophenolate and CellCept were equal. So in the graph on the top, you can see the error bars cross each other, so it's not that one's better. But if you look at the people that dropped out, the people with cyclophosphamide, survival probability means the number of people who kept on the medicine. The cyclophosphamide folks dropped out because of side effects. So cyclophosphamide is a very toxic medication. CellCept is better. CellCept is procurable in Kampala. I've checked. It's expensive, so it would be only some patients. But if you have patients with scleroderma and they have lung disease, this would be the treatment of choice. It requires monitoring. If you ever have a patient like that, please email me. We'll talk about it. But it is a therapy. And it doesn't hurt your immunity as much as like high-dose steroids. So you don't need to put people on Bactrim prophylaxis if they're on CellCept. Exposure-related ILDs. So you've got inorganic dusts and organic dusts. I have them listed there. Oh, and I put drugs in the same bucket. And you can see this is pneumoconiosis. These are pathologic specimens. Our second patient is a great example of silicosis or pneumoconiosis, most likely. Could be cancer, could be other things, but I think most likely. And what she has is what's all the way on the left. This is in coal workers, but the first is what we call a diffuse pneumoconiosis, and then the third panel to your right is what they call progressive massive fibrosis, which is the end stage in silicosis or coal exposure. Usually characterized by these big nodules. You remember her x-ray had this big hilar nodules and this fibrotic pattern that's pulling the lung parenchyma in. There really is not much you can do for these patients once it's there, okay? You can remove the exposure and you can prevent future disease. So if you find out that there's a bunch of people working in a quarry that are getting this disease, it probably means that they're having, really bad work environment. And so trying to make change as much as we can, also something difficult, I recognize. But, and there's no clear role for steroids. In the US, these patients are referred occasionally for transplant. Patients with organic dust exposure usually start by having more of an inflammatory pattern. So you can see in the upper lobes, in panel A, you can see this diffuse ground glass attenuation. It looks like you're looking through the lung through a hazy glass, right? And that's sort of indicative of inflammation. And you can see it's upper lobe predominant in panel B. You can see that the upper lobes really are demarcated and the lower lobes are relatively spared. This is what we usually see in hypersensitivity pneumonitis. So these patients, like according to my rules, you remove the exposure. And in these people, you can give steroids. And that's the general regimen. I put it there only if you have a patient you think that has this. You can look back at these slides. Sarcoid. I'm already over. Let me go quick. So it's usually pretty common. It's difficult to diagnose and can affect any organ. There's some people who say that they don't think that sarcoid is very common in sub-Saharan Africa. I think that's untrue. Judging by my limited experience here, I think I've already seen like 3 or 4 cases. I think the difficulty is that we have to rule out TB in our setting and really rule it out, right? So this is the role of bronchoscopy, I think, is really here to rule out the things that would confuse you about the diagnosis. And ruling out TB with bronchoscopy is relatively easy. I think if we do that, you can start to increase your pre-test probability that this is going to be sarcoid. Sarcoidosis, it generally resolves. So if you find out that it is sarcoid, it doesn't mean it needs to get treated. And treatment is stepwise and dependent on symptoms. So if a person feels fine and for some reason they got a chest x-ray and it looks like they have sarcoid and they feel fine, please don't give them steroids. You're just going to give them trouble. Okay? But if they're feeling sick, then you can initiate steroids. Usually that's the regimen there. There are additional medications for resistant disease. And if they have cardiac and neurologic findings, start high dose. You should also continue to monitor people with sarcoid. So I thought I would talk a little bit about IPF because it leads to something interesting. So for a while it was really lousy to be an ILD doctor. We had very few treatments up until 2014. And the main thing you did was counsel patients and then try to get them transplants. Idiopathic pulmonary fibrosis is the most common interstitial lung disease in the United States and Europe. And it has a really bad prognosis. So at 2 to 5 years, over 50% of the people are dead that have it. They had tried, I think, over 20 different molecules trying to treat it. And then they even had one that was really harmful. So this was the Panther trial, and you can see that the combination therapy was the time to death. So those were the people getting treated and more people were dying. That's what people were doing for about 6 years before they had this trial. And it was stopped early because we were harming our patients by what we were doing. So then 2014 came along and we got not just 1, but 2 drugs that came out. And these graphs are looking at the primary endpoint, which was decline in lung function. And you can see that over time, the solid line in the nintedanib group is higher, meaning that their lung function was more preserved over time than people who took the drug. And in the pirfenidone trial, you can also see that the change in lung function was less, meaning there was less decline in the pirfenidone group, the top line. And in the pirfenidone group, there was also a trend towards progression-free survival. So it actually helped people live a little bit longer. These are the 2 trials. I'll skip over it, but only to say they are extremely expensive drugs, $90,000 US a year. That's crazy. Everybody gets side effects, pretty much. About 30% of people get nausea and rash in the pirfenidone group, and about 60% will get diarrhea in the nintedanib group. So when my patients come in and ask me about starting a drug, I ask them, do you want to have diarrhea, or do you want to have rashes and nausea? And whatever they tell me, those are the drugs we choose, because they're certainly going to get a side effect. They are they do have a place. And I think as time has gone on, we've found in longitudinal follow-up that these do save lives. Okay, so if you follow patients for long enough and you prevent their lung function from declining, people will live longer. So both of these drugs save lives. They're just hard to take and they're really expensive. Okay, so what does this mean for the future? So I think we've all sort of touched on the fact that people with a variety of lung diseases can have biopsies that look the same, CTs that look the same, and when we follow people who look the same on biopsy and CT, even if they have rheumatoid arthritis, even if it's because they were exposed to birds, they generally do the same. People die almost as quickly if they have as bad looking CT scans and as bad looking biopsies. Okay, so these are 3 different reasons why people have lung damage. Okay, can you tell which one of these patients is hypersensitivity pneumonitis, which one of these patients has asbestosis, and which one of these patients has IPF? Can anybody tell? I can't. Okay, and I'm the director of an ILD clinic. So the thought was, if it all looks the same on a biopsy, and it's all acting the same, and it looks the same on a CT scan, maybe all of these drugs would help. Okay, so they started to do trials looking at that. So this is kind of just showing that all these things can end up having a fibrotic lung disease and sort of look like IPF. So they did the trial, census trial. This was in May of 2019. And they took people with scleroderma ILD with fibrosis on their CT scan, and they gave them nintedanib, this drug that causes a lot of diarrhea and was for IPF patients. And it slowed down the decline in lung function. Okay, so it works. It works for fibrotic lung disease if you have an autoimmune disease. These patients were also being treated with immunosuppressive therapy. So they were being treated for scleroderma as well, but it slowed it down beyond what a placebo did. Then there was this really interesting trial that just happened. Okay, it was called InBuild, and this was released in October 31st of this year. So this was like a month ago. And what they did was they took patients with over 10% fibrosis on a high-resolution CT from any cause. So you can see that there was a lot of people with hypersensitivity pneumonitis, a lot of people with autoimmune lung disease, a lot of people with IPF, a lot of people with unclassifiable ILD, and they gave them all, they gave one half nintedanib and the other half a placebo. And it slowed progression of lung decline. Okay, so it seems like it may not matter why you have fibrosis and that we might have therapies. And if you have therapies like that, what happens is they get cheaper. Okay, so these may be far off for us here, but I think in time they may be available. And I think there may also be the possibility of trials that we could get these things in the future. All right. So a specific question that I had for you guys that I've been thinking about. So if you saw this patient in your ward, what would you think this was?
TB lung.
Excellent. Okay. Yes. Right. TB lung disease. And really post-TB, right? It looks like this person has had TB, they had scarring, it destroyed their lung. I've seen a lot of these patients so far, and I've only been here for 2 months. And I'm sure I'll see a lot more in my next 10 months. So the tuberculosis patients have the same elevations in cytokines that patients with IPF do when they have post-TB fibrosis, okay? So the question is sort of, do you think that nintedanib or pirfenidone would maybe prevent this? If you had a patient who you thought was high risk for fibrotic lung disease following TB, could it prevent it? So I did a little digging, and there was one study where they tried and it was actually bad. So we have ways to go, but I do think that it leads to an interesting question. They did this animal study in rabbits who had TB, they gave them pirfenidone and they had more cavitation and a little bit more resistant bacteria. So we're not ready yet, but they've never tried nintedanib, so you never know. And I think that it could be a future direction for study. So with that, I'll take questions if anybody has them.